We are very fortunate in Denmark that we have wide possibilities for register-based research. And the benefit of register-based research compared to clinical trial presented by Professor Dressler is they are very cheap to perform. And in Denmark we have a wide range of registers, and the main advantage in Denmark is that we have a unique personal identification number, a social security number, that allows us to connect registers of hospitalizations, of drug dispensing from pharmacies, and also a wide range of socio-demographic registers of education and even taxed income to define socioeconomic status. And then we have also registries of causes of death and date of death. And by using this unique social registration number, we are able to combine these registers. What I will do in this presentation, I will present to you a number of studies, a number of problems we have addressed by register-based trials. And as Professor Dressler pointed out, there are not all questions that we are able to address in clinical trials. The first issue I want to look at is NSAIDs. And there has been a lot of discussion about the cardiovascular safety of these drugs, and we were aware of it when the COX-2 inhibitors were presented, that there were problems with these drugs. They increased cardiovascular risk. And then we wanted to address, what about the conventional NSAIDs? Have they the same problem as the COX-2 inhibitors? And as you can see in this figure, NSAIDs are widely used in the population. And you can see with this red line, approximately 40% of the population has claimed a prescription of an NSAID during a 10-year period in Denmark. So it's a huge public health issue. And we know that from this figure, you can see there are a wide range of systems that NSAIDs can influence. You have the cardiovascular system, you have the kidneys, and you also have the heart. So what we did a register-based trial, and we looked at patients with myocardial infarction, and to see what was the prognosis of. I have some problems with the. Yeah, you'll get opportunity to see it again. And as you can see on this figure, the patients who are receiving NSAID at the time of infarction, they have a worse prognosis compared to patients that are not receiving NSAIDs. And then we looked at patients who continue to use NSAIDs after discharge with myocardial infarction. And as you can see on this figure, I'll try to explain it to you. You have these are hazard ratios, and these are the individual NSAIDs. And here you have a line demonstrating a risk of 1 that means no risk, and these are the reference patients that are not receiving NSAIDs. And here you have the hazard ratios, and as you can see, these are the COX-2 inhibitors. Patients taking high dosages of COX-2 inhibitors after myocardial infarction have approximately 5 times increased risk of death. And you also see a very commonly used NSAID like ibuprofen and diclofenac also increase the risk of death, and diclofenac as high as the COX-2 inhibitors. So it seems like NSAIDs have a adverse effect on adverse cardiac effects on outcomes in patients with myocardial infarction. And then we looked at, because recommendations say that if you want to give NSAIDs with patients with cardiovascular disease, you should use it for a short time period as possible. And what we looked at was, does it matter? And this is time in weeks, and these are NSAIDs, a risk or absolute risk increase, and this is the risk in the background of population. These are also MI patients. And there seems to be a continuously increased risk of death and myocardial infarction in patients with MI. And you can see that it doesn't depend on time up to 14 weeks of treatment. The risk is already increased at start of treatment. Then we looked at another issue with NSAIDs. That is the risk of bleeding. And this is in patients also with myocardial infarction. And this is a very recent population in JAMA. And we differentiate them, those who are receiving clopidogrel and aspirin, that is commonly the recommended treatment for patients with recent myocardial infarction with a risk of 1. And then you can see if you add an NSAID on anticoagulation treatment or antithrombotic treatment, you have up to 4 to 5-fold increased risk of serious bleeding. These are major bleeding requiring admission. And as you can see, this is just to visualize that the increase is very high during start of treatment and decreases with the duration of treatment. So this demonstrates that you shouldn't combine NSAIDs with antithrombotic drugs. Another issue, and I know that Professor Agarwal talked about this, was about clopidogrel and proton pump inhibitors. There has been a lot of discussion about the interaction between clopidogrel and proton pump inhibitors, and that they could decrease the bioavailability or the efficacy of clopidogrel. And what we did was to do a propensity match analysis where we matched patients on the propensity score of receiving clopidogrel, and we found that there is a difference in risk of myocardial infarction and cardiovascular death with proton pump inhibitors compared to no proton pump inhibitor in patients receiving clopidogrel. But we also saw that in patients not receiving clopidogrel, there was also the same increase in risk. So there is something about proton pump inhibitors, if it's confounding because they have more comorbidity, or some individual effect of proton pump inhibitors. And it's not related to clopidogrel. And we also did this in a Cox regression analysis, and we find that generally proton pump inhibitors increase the risk by 40% of adverse events. And we also looked at what about aspirin, because proton pump inhibitor decrease the acid secretion in the stomach. It could reduce the absorption or the bioavailability of aspirin, and we find the same for patients just receiving aspirin after myocardial infarction. And if you add proton pump inhibitors, they have higher risk with a hazard ratio of 1.6. And what was interesting in this, we didn't see any difference between the individual proton pump inhibitors. And if it looked at the old H2 receptor blockers that are also used for the same indication, we did not find the same increase in risk. So it seems to be something about proton pump inhibitors that could increase risk. We have done a lot of studies on antithrombotic treatment and combination of antithrombotic treatments. And this is a study we published 6 years ago in the Lancet about what in patients with myocardial infarction if we combine different antithrombotic drugs and the risk of bleeding. And as you can see, if we combine compared to aspirin alone, and if you combine it with up to 3 antithrombotic drugs, you increase the risk by factor 4 for a major bleeding. And what we also find that it does seem like that even though we have an additional antithrombotic effect of triple therapy, it doesn't reduce the risk of death. So that's a major problem. We have also looked at it in another population. These are also MI patients and with atrial fibrillation, and we see that the risk of bleeding. These are the crude incidence of bleeding with triple therapy. This is the thick red or brown line here. It's very high during the first 30 to 90 days, and then it's very stable thereafter. And you can see that compared to triple therapy has the highest risk, and this is dual therapy with oral anticoagulation and antiplatelet. And so there is a balance here. You increase the risk of bleeding with antithrombotic, with triple therapy, but you also have the lowest risk. But compared to dual therapy, that is a single antiplatelet with an oral anticoagulation, you have a very, at least lower risk of bleeding, but you have the same antithrombotic risk of thrombosis. So it could be that there was, at least in patients with a high risk of bleeding, it could be advantageous just to combine two drugs, oral anticoagulation with a single antiplatelet. And this is a hazard as what we want to analyze risk of different endpoints. And you see the steepened line here. These are patients on triple therapy, and these are patients with an oral anticoagulation and the clopidogrel, and the yellow here is for oral anticoagulation and aspirin, and this is aspirin and clopidogrel alone. They have a higher risk of coronary death and stroke if you just give antiplatelets to patients with atrial fibrillation and recent MI. You get a higher mortality, and it seems like what is important that dual therapy has a lower risk of bleeding, but the same risk of same protective effect on MI and coronary deaths. And the other issue is in patients with atrial fibrillation, how long should we continue to combine an antiplatelet with an oral anticoagulation treatment? These are patients with atrial fibrillation and stable ischemic heart disease, and that means there is at least 1 year after the myocardial infarction or a coronary intervention. And you see at different endpoints. These are the combined endpoint of stroke, myocardial infarction, and cardiovascular death. These are for major bleeding, and these are for all-cause mortality. And we have the reference, which is a monotherapy with oral anticoagulation therapy. And you see that for triple therapy, you have an increased risk of cardiovascular death, stroke, and myocardial infarction. And you also have increased risk of all-cause mortality, and you also have a substantially increased risk of major bleeding. So it seems like in patients with myocardial infarction or with stable ischemic heart disease and atrial fibrillation, it seems like that oral anticoagulation alone with a warfarin is as protective as combining it with antiplatelet, and you also lessen the risk of serious bleeding. And this is another study we published, and these are patients, and there has been a lot of controversy about patients who have been operated for and received a biologic aortic valve prosthesis. And current recommendations say that you should give them at least 3 months oral anticoagulation after therapy, and these are patients without atrial fibrillation. But the evidence is based on a very, very small trials, only including 450 patients, and there were very, very few events. So we did a nationwide study where we included all patients who had an aortic valve prosthetic operation without atrial fibrillation and did not need oral anticoagulation due to other indications. And what we found that you can see here, these are different endpoints. This is the endpoint for stroke, and this is a combination of thromboembolic events, and this is for cardiovascular death, and this is for bleeding incidents. What is important to notice is if you look at cardiovascular death, you have a much higher risk of patients during the first 90 days and the first 180 days. You have a much higher risk of cardiovascular death compared to those these are the black dots of patients receiving anti-warfarin treatment and those who are not. And there seems, at least in this study, that you should at least give all patients oral anticoagulation for 3 months, and there could be that they should receive oral anticoagulation maybe for 6 months. So just to conclude on this presentation of different studies, we find that registers are very important research and tool for research within cardiovascular disease. But when you perform a register-based trial, you need to be very careful about considering methods and statistical analysis. You need to select your cohort very carefully, and you need to be very precise of using proper statistical methods. And you need also to take into account risk of bias and confounders, which you maybe not have registered in these registers. And you also need to be very careful to interpret this research, because register-based trials and observational studies are not able to confirm causality, but they show association. They could generate new hypotheses and guide us in designing appropriate randomized clinical trials. So thank you very much for your attention.